Good afternoon, everyone. My name is Andrew Watkins, and I work with Mindgardens Neuroscience Network as the Director of Programs and Innovation. I'd like to first of all start with acknowledging the strength and resilience of Aboriginal and Torres Strait Islander people, who are the traditional custodians of the diverse countries from which we're joining this meeting. I'm privileged to be calling myself today from the land of the Gubbi people, and I'd like to pay my respects to elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander people present today. I also importantly want to acknowledge people with lived experience of mental ill health and recovery, and the experience of people who have been carers, families, or supporters. Welcome everyone to the Mindgardens Psychosis Webinar Series, which is part of the Mindgardens Tertiary Referral Service for Psychosis, or TRSP. Now, TRSP, for anyone who might not be aware, is a statewide service that is funded by New South Wales Health and hosted by South East Sydney Local Health District. Mindgardens is grateful to both CESLED and New South Wales Health for their ongoing support of the TRSP. So TRSP aims to improve the lives of people living with complex psychosis. It does this through delivery of a clinical service which welcomes from right across New South Wales anyone living with psychosis and receiving care from public mental health services. It also runs education and training programs to build capacity in caring for people living with complex psychosis, and this webinar today is one example of that capacity building. The webinar series is supported by Mindgardens Neuroscience Network. For those who may be unfamiliar with us, Mindgardens is a partnership between our founding members, Neuroscience Research Australia, the Black Dog Institute, UNSW Sydney, and South East Sydney Local Health District. Mindgardens was established in 2019 to enhance collaboration between those founding members, bringing together clinicians, researchers, health service administrators, and people with lived experience to design research and quality improvement projects that can be translated into everyday practice, matching consumers' priorities, and the idea is to make a real difference in people's lives. These webinar series will be running monthly throughout 2025, so please keep a lookout for emails from Mindgardens which detail future webinars, all tailored for clinicians. A little housekeeping for the rest of the webinar. You have seen a couple of polling questions. If they haven't gone up already, will go up soon. We really would appreciate if you answer them for us. Those answers will be anonymous, and they do help us to constantly improve the content of the webinars and to deliver what is needed. We will save time at the end to have a Q&A session, so please add any questions that you might have to the little Q&A window on the Teams page. We also appreciate your feedback in the chat window or by email. So if your question isn't answered or you'd like to share any suggestions with us for future webinars topics, please feel free to contact us at our website, which is contact@mindgardens.org.au. This webinar will be recorded and distributed to all registered attendees within a couple of weeks of today's presentation. And finally, it's my great pleasure to introduce our speakers today. We actually have 3 speakers, and I'm going to introduce Dr. Adith Mohan first and allow him to introduce the other 2 speakers when he first comes online. But Adith is currently a consultant neuropsychiatrist and clinical director of the Neuropsychiatric Institute at Prince Wales Hospital, Sydney. He's also a research fellow with the Centre of Healthy Brain Ageing and a Conjoint senior lecturer with the UNSW School of Psychiatry. Adith's current research interests include clinical care implementation and evaluation in functional neurological disorders, or FND, functional cognitive disorders, transcriptomics.
It's totally fine. I understand it very much, so don't worry.
This is like a tongue twister going through your bio. Of human brain aging, as well as therapeutic neuromodulation and novel treatments in neuropsychiatric disorders. He is the Chief Investigator on a clinical research program investigating a novel interdisciplinary clinical program in FND and is currently leading the establishment of a world-first clinical consortium for FND clinics in Australia and New Zealand. Now, if you haven't worked it out already, Adith is a very busy man. And I don't know if Adith actually has time to sleep with all his roles, but particularly close to our hearts, Adith is also the project lead for the Mindgardens Neuroscience Network's Functional Neurological Disorders Clinic, which is great. Please join me in welcoming Adith and his co-presenters, staff specialist neurologist, Dr. Emily O'Keefe, and UNSW Psychiatry Registrar, Dr. Matthew Lennon, presenting the expanding frontier of immunopsychiatry. Over to you, Adith.
Thanks, Andrew, and thanks everyone for coming. I can see there's about 50 people on the call, although I think that might include us. So I'm going to say about 40 people on the call. Look, thanks for the opportunity. And I really should say it should be the other way around. It should be Emily and Matt presenting with me, sort of doing a very weak intro. And I didn't have pictures of them, and you had this giant picture of me. I should make mine really small. And I've stolen Matt's off just now, and I had to screenshot Emily, so I'm sorry. But you know, they're really carrying this presentation, and my job is really to set them up. But to set up the talk in a sort of more cohesive whole, I want to take you through what immunopsychiatry actually means, and it's particularly relevant to this audience, relevant to, I think, the work that TRSP does more broadly is this sort of dream of precision medicine and psychiatry, and this idea that some of what we can offer our patients, which is reality for a number of other disciplines, is the opportunity to have disease-modifying treatment. A lot of what we do, predominantly what we do, is offer symptomatic treatment. What we almost accept is that we don't have therapies to change or alter the disease course in an individual who has a psychiatric presentation, and in this context, the psychosis-like presentation. And I think that's sort of really feeds into what immunopsychiatry is and what the promise of it could be. In terms of where Matt and Emily will come in, I'll sort of do a quick intro to the field. Matt's going to take us into the more specific aspect of what we think of as being autoimmune encephalitis, which is, I guess, a specific area of immunopsychiatry, but perhaps the one that's really catalyzed change, and I'll tell you why. And then Emily will take you through some work that she's led in her role as a neurologist, and we're lucky to be collaborators on it. And Matt and Emily have sort of put that together in a paper for publication, which we hope will generate some interest. So without sort of too much further ado, you know, inflammation and interest in inflammation is a feed into psychiatric presentation. And I don't just mean psychosis. I mean, in fact, more so than psychosis, things like depression and anxiety. This is not new. And it's important to separate out what we're going to talk about from the sort of broader field of inflammation, which is really thinking about peripheral inflammation, things like pro-inflammatory cytokines, IL-6, IL-1, TNF, and how these pro-inflammatory states, if you will, influence brain function. And, you know, I have this figured down in another slide, but fundamentally, this is one way of pulling that together, that in fact, inflammation as a state, and this is sort of going away from our traditional dualism between mind and body, or in this case, central nervous system and peripheral immune system, that these interact with each other. And, you know, we've moved away really from what used to be thought of as the brain being immune privileged, that the brain was not influenced by peripheral inflammatory states. But this story has been told since the early 1900s. And it's really sort of taken another life now, and I'll take you through that. But so the field of psychoneuroimmunology is not new. And a lot of what I'm talking about is that interface between neuroimmunology, immunology, neurology, and psychiatry. And that field goes back decades. I think that the conversation at immunopsychiatry starts more so within the last decade, which has really taken what might be thought of as a bench to bedside approach. This promise of translating these conversations into real world treatments. That's the holy grail. And that's probably where the sort of more peripheral discussion about peripheral immune system and that pro-inflammatory state as being a driver of illness hasn't translated into practice. There are multiple trials, some of which we've been part of, that have investigated the use of anti-inflammatory agents in conditions like schizophrenia, celecoxib, minocycline, monoclonal antibodies, and the bang for buck, if you will, in terms of treatment impact has been measurably small. And I think the interest in that was starting to feel a little bit more bench and a little bit less bedside. And that's not what our patients are after. And a lot of the work that I do, a lot of the work that we do here, both at the Neuropsychiatric Institute, but also in my collaboration, Mindgardens, and Andrew talked about this at the start with FND, our sort of general interest is in translational research. What can we do with immediacy of impact? And how does that look in the real world? So, when you talk about immunopsychiatry, and I haven't looked at this for the last 4 years, I suspect that number would be much higher. But it sort of sets this contrast up for you that we've been talking about psychoneuroimmunology for a very long time, but we're talking about immunopsychiatry more recently. And I think the key difference there, and you keep that in mind for the framing of this talk, is going to be about how do we take this into practice? What are the gaps that we're trying to address? But if I take you back, we've been talking about inflammation in psychiatric disease for 130 years. And we've been talking about it all the way back to Kreplin, one of our early figures, really talking about the potential for infections to cause what we now call schizophrenia, what at the time was considered dementia precox. People like Carl Menninger talked about the schizophrenia syndrome following influenza, and the influenza pandemic is a key event. It's a key event in our understanding of inflammation in psychiatric disorders. Going back to that field of psychoneuroimmunology, for those of you that aren't familiar, there was essentially this epidemic, if you will, of this encephalitic syndrome, where people presented with Parkinsonism, catatonia-like states, mutism, and really the sort of quintessential neuropsychiatric illness, if you will, affecting sort of quite a large number of people in the aftermath of the flu pandemic. And of course, given the science at the time, and possibly even given the science now, establishing causality with the flu virus wasn't possible. And you'd argue that the flu virus isn't causal. It's the immune system that's the mediating link. But it really set off this interest. But it was Lennon, Pashas, who first talked about the potential for antibodies to attack brain tissue, which is questioning that immune privilege question: is the brain is considered protected from system level inflammatory insults? And that's really where we find ourselves, I guess, now. If I go back to the bottom box there, the idea of the blood-brain barrier, this sort of endothelial tight junction barrier, being impermeable, and protecting the brain in an absolute sense, and how that is now proven to not be the case on a number of levels. And so the brain is communicating with the immune system, if you will. A lot of what I've talked about so far would sit under that sort of idea of a cytokine storm that people with, and work that's been done here, work from people like Cindy Wykett's group that have subtype people with schizophrenia into these high inflammation groups and low inflammation groups, leading to the monoclonal antibody trial that Cindy led, sort of going back 5 years now. The idea that there were people within our cohorts that were inflamed peripherally. What we've seen come into that conversation is the role of microglial activation. And this is sort of a conversation that is relevant to some of my work in my PhD work, which is looking at neuroinflammation from a molecular perspective, looking at glial cells and microglia in particular. These are brain cells that serve a homeostatic purpose. They serve a developmental purpose in the context of what we're talking about. These are the cells that control essentially which synapses. You're born with a lot of synapses, and then there's a process of functional synaptic pruning that really consolidates brain development and maturity. And that sort of loss of synapses that's functional and developmental, the idea here is that you have activated or inflammatory phenotypes of microglia that go berserk with that pruning process, leading to network level disturbance and leading to problems in the way information is processed in the brain. Fundamentally, you talk about any psychiatric disorder, psychosis, depression, whatever, you're talking about the way networks process brain information. And the idea of glial cells, and when we come on to talk about autoimmune encephalitis, we're still talking about network level disruption, leading to the way those networks conduct information in the brain, right? And the cytokine hypothesis, and I might not stay with this for too long because I'm mindful of the time. These sort of large cohort studies, Danish registry studies that have established links between people that have had, in a dose response kind of way, multiple admissions with infective disease and have later developed psychiatric illness in a way that is a much higher risk than people that haven't had those admissions. So these millions of people in cohort registers. And the same thing, the same kind of discussion around synaptic pruning and schizophrenia that you have that ties the sort of nature-nurture thing together. You've got these early life complement variants that set up a genetic predisposition. You then have a hit from an infective pathology, either during maternal illness. So this is that sort of story about maternal infections being a risk state for the later development of schizophrenia. And then you induce essentially this primed state of inflammation at the brain level or the microglial level that takes another hit to then set off the disease process, whatever that hit may be. But this is where we're at now. And this is sort of setting up Matt to go next. What changed the game, I think, in many ways, and this is, what's brought us into partnership with people like Emily and Julia Thompson, who's our other collaborator on this paper, and some of the clinical work that we're planning to do in this space, is the 2007 case report of anti-NMDA receptor antibody encephalitis. This is the closest thing to a pure psychiatric phenotype. At least an early stage illness where you could define a pathogenic antibody, essentially a causal antibody, and break that down into the brain mechanisms that drove that presentation. So the fact that these antibodies attach themselves to a subunit of a surface receptor, the NMDA receptor, the fact that those receptors get cross-linked and internalized and degraded, and how that plays on in terms of network level activity, particularly glutamate related transmission, and how that sort of synaptic story could really be studied in this group where there was a cause, a very specific cause. And you really see this. To people like me that sort of work in the field, I would see this as that catalyst for immunopsychiatry, that thing that told us as a field, hey, there are people with psychiatric presentations where we can do better than symptomatic treatment, because truth be told, we're nowhere near disease-modifying treatment other than what we're going to talk about today. And so it's really the new frontier of treatable mental illness, and by treatable we mean disease-modifying, not treatable as in symptomatic. And we'll talk about, through Emily's talk, some of the challenges that sit here. And so this is really that sort of life course of NMDA encephalitis, and we'll flesh this out a bit further. An illness that has clear phases, an illness that has clear cause, and an illness that is completely reversible if you can clear the pathogenic autoantibody, right? The holy grail for psychosis. And, this idea, but the question that immediately followed, that how many people with lifelong schizophrenia could be treated if we had found them out earlier? And there's a spectrum of asking that question, and that's the work that Em is going to present. It's who do we pick up and who do we treat? Great, we've got this thing and we can do this wonderful thing. And this is every patient that I've seen. I've been a psychiatrist and neuropsychiatrist for upwards of 20 years. This is what they will ask you. Is this what's going to happen to me? And can I be better? And if you say to someone, and if you ask this question of the hundreds of thousands of people that we have with schizophrenia living in this country, can we make this go away? Then we're asking a big question with a lot of valence, right? And so we've gone from history to sort of where we are, but the missing middle here, and that's why the middle's blank is we've got the molecular precision and we've got the insights. What we don't seem to have is the accurate ability to pick up the people that we need to go ahead and treat. So I'm going to hand over to Matt. Thanks, Matt. Take it you can drive.
Thanks very much, Adith. That was a really good introduction to what we're going to talk about. I'm just going to take control. So I'll only speak for about 5 minutes, but this field of immunopsychiatry is really growing quickly, and there's increasing awareness as we discover more antibodies that there are people who are classified as first episode psychosis, who are thought to have primary psychotic disorder, who on further investigation are actually found to have autoimmune encephalitis or another immune mediated process. So some of these studies, and Adith, I might need you to keep changing the slides. So
Yep.
In one of these studies, Blumedal 2016, that was sorry, if you want to go back. They looked at 116 people presenting to a Queensland hospital. Initially, the cohort had about 155, but 116 people consented to be part of the study. And of the 116 people, 5 patients were found to have anti-neuronal antibodies from plasma samples, and they received immunotherapy with reasonable good outcomes. So on a larger systematic review, Nicola Warren in 2023 published this study including 2,754 people looking specifically at GAD IgG antibodies, and they found that interestingly, the percentage of people with first episode psychosis or psychosis who were positive for GAD was actually lower than that of controls. So you had kind of 31 people who had all low titer having positivity for GAD antibodies, but none actually met criteria for autoimmune encephalitis. And this raises the complicating factor of false positives, and we know that in any diagnostic test, we are going to have false positives. And Nicola Warren, in a talk I heard her give at the end of last year, made a really good point that if we routinely do autoantibody testing of a whole panel of 20 autoantibodies on every patient who has psychosis, the probability that we're going to get false positives for at least some of those patients, for at least some of those autoantibodies, is very high. And we need not just to look at numbers and not just to look at diagnostic tests, but to be really judicious in the way that we clinically correlate symptoms with what we see, and that we repeat tests to make sure that we're not just picking up false positives. And in that kind of systematic review, she also found a number of cases that there was a clear clinical correlation between anti-GAD antibodies and psychiatric presentations. So not, I suppose she was making the point in that paper that this is not an evidence-free zone, and certainly there is evidence that it can cause these clinical symptoms. So then, with that in mind, the question is, how do we actually diagnose autoimmune encephalitis? And kind of the seminal paper in this area is this paper in Lancet Neurology by Grouse et al., of whom the senior author was Joseph Dalmau. And they said, when we're thinking clinically and we want to identify who has possible autoimmune encephalitis, we have to have, they proposed 3 criteria. So the first criteria is subacute onset, so rapid progression of less than 3 months of working memory deficits, so short-term memory loss, altered mental status, or psychiatric symptoms. And at least one of the following, including new focal CNS findings, seizures not explained by previous known seizure disorder, CSF pleocytosis, so having a white blood cell count of more than 5 cells per millimeter cubed, and MRI features suggestive of encephalitis, as well as reasonable exclusion of alternative causes. So in terms of the imaging findings in autoimmune encephalitis, this is interesting because this is in this Grouse et al. 2016 paper, and it's here to show you on T2 flare MRI sequence using an axial section what the classic presentation looks like of autoimmune encephalitis, and that we see in panel A. So it's this increased T2 hyperintensity signal seen bilaterally in the kind of anterior and medial temporal lobes, where it's essentially this kind of edematous inflammation. And this is like classic limbic encephalitis, autoimmune encephalitis findings. The other things are various different mimics of autoimmune encephalitis. So panel B is actually a local edema from a glioma. Panel C is a white matter disease. Panel F looks like CJD, but is actually another form of autoimmune encephalitis. I think I want to say I can't remember the exact antibody, but essentially that they were saying that this actually is autoimmune encephalitis, even though it looks more like CJD. And then these are kind of other things that they all have some semblance to this classic picture of autoimmune encephalitis, but really this is the kind of thing that you're looking for. The next slide. In terms of making a definite diagnosis of autoimmune encephalitis, the Grouse et al., sorry, this should say 2016, said that a diagnosis can be made when all four of the following criteria are met. So again, you need subacute onset, rapid progression of less than 3 months of working memory deficits, seizures or psychiatric symptoms suggesting involvement in the limbic system, bilateral brain abnormalities on T2 weighted fluid attenuation, so flare MRI imaging, generally that are restricted to the medial temporal lobes, and at least one of the following: a CSF pleocytosis with white blood cell count of more than 5 cells per millimeter cubed, and an EEG with epileptic or slow activity involving the temporal lobes. Next slide. But this kind of more strict definition of autoimmune encephalitis is not what all researchers and psychiatrists subscribe to. And notably, there is a group at Sydney University who are exploring more ideas of not just a restricted view of autoimmune encephalitis, but a more diverse and open view of neuroimmune-mediated major mood or psychotic symptoms, or neuroimmune-mediated neuropsychiatric symptoms, so NIM-NPS. And that NIM-NPS has 2 categories. The first category is this atypical mood or psychotic symptoms, so AMPS, and the other category is autoimmune encephalitis. What comprises atypical mood or psychotic symptoms, you might ask? Well, they say it's things like sleep-wake disturbance, cognitive disturbances, autonomic nervous system disturbances, and things involving appetite, as well as some other flags like treatment resistance and kind of other bizarre or intense symptomatology. So just in June of 2025, they put out this really interesting paper looking at a case series of about 45 patients who have had a range of symptoms that they thought had neuroimmune-mediated neuropsychiatric symptoms. So these patients had depression, psychotic features, treatment resistance, neurological symptoms, and these patients, they were generally young, so I think they were between the ages of 18 or 17 and 30. They all had a long illness duration of nearly 5 years, median 3 years, and autoantibodies were detected in a serum or CSF of 64%. So that is a huge difference to kind of the general screening numbers that we saw previously in the Queensland study and Nicola Warren study between 0.3 and 3%. So nearly 2/3 of these participants. And 91% of these patients showed some form of elevated inflammatory markers. The vast majority, so 43 out of 45 of these patients had immunotherapy. And the results, as published by the paper, are pretty phenomenal. So 88% showed clinical improvement, 79% maintained long-term benefits. They had an increase in this like functioning score, the SOFA score, and their NEAT is not in education, employment, or training, and that declined from 81% to 14%. And the rate of psychiatric hospitalization also dropped radically. So from 93% to 7%, and they also stopped using psychotropic medication, going from 84% to 9%. But 79% did have adverse effects, with about a fifth experiencing moderate to severe complications. So this is just kind of a little bit of a background of the variety of thoughts and thought processes in this field. And how there are some interesting findings showing potential benefit. But I might now hand over to Emily, who's had a look at the data coming out of Prince of Wales Hospital in our local area, to talk about what we've found.
Thanks, Matt. I'm just going to try and see if I can take control. Otherwise,
it looks like you can take control of this screen, but not clicking through the slides, I think.
I see.
So
okay.
I'm happy to drive. Or hang on, let me try this. Can you try now? Just see if you can click through. Oh yeah, there you go. Okay.
Thanks. Beautiful. All right. So my name's Emily, and I'm going to be presenting some of our findings from a study that we collaborated on, based out of Prince of Wales. So essentially, I feel like the research itself was born out of lots of discussions between neurology and psychiatry, where I feel, neurology is worried about over-investigating primary psychiatric conditions. Psychiatry is concerned about missing early diagnosis of autoimmune encephalitis. And I thought it might be time to crunch the numbers and find out how we're actually doing. So let's see if I can go next. Oh. Let's just try again. There we go. Perfect. So these are just our affiliations. So what was the diagnostic challenge? So first episode psychosis presents, a complex diagnostic challenge, because psychotic symptoms could herald a primary psychiatric disorder or could be secondary to an underlying medical condition like autoimmune encephalitis. And the treatment approaches are markedly different. Autoimmune encephalitis requires early intervention with immunotherapy, and first episode psychosis also requires its own early intervention, particularly with antipsychotic management and input from the psychiatry teams. And these are all really time-sensitive outcomes. Delayed treatment particularly can impact outcomes for both patients in terms of long-term, both patient groups in terms of long-term prognosis. But ultimately, there's still a debate remaining around which clinical features most reliably suggest an autoimmune etiology and should trigger further investigation. So we did a retrospective case control study which spanned patients who'd come through Prince of Wales between December 2015 to December 2024. And overall, this involved 122 participants or patient cases being selected, 18 of which had confirmed autoimmune encephalitis and 104 with first episode psychosis. We screened about 567 cases and excluded 454 that were purely medical and others that had established psychiatric diagnoses. Given the sample size, though, we decided to focus on a more descriptive set of statistics as well as univariate associations rather than a more involved multivariate analysis. So moving to our next slide. So what were our objectives? We had 4 clear objectives. One was to identify the distinguishing clinical features between autoimmune encephalitis and primary psychiatric disorder in our patient cohort. We wanted to compare how we were investigating each group, evaluate how we treated them and the timing of the treatment. And we ultimately want to develop some practical clinical guidelines to help us. So this is just briefly our inclusion criteria, which I might jump over for the sake of time. So looking at our demographics, there was a clear difference between the two groups. So in particular, the autoimmune encephalitis group was significantly older than those presenting with first episode psychosis with a mean age of 47 versus a mean age of 35. There was also stronger female predominance in the autoimmune encephalitis group, so 67% versus 43%, but it wasn't statistically significant. But what was interesting was hospital stays. So hospital stays were significantly longer in autoimmune encephalitis groups, and we might touch on a little bit later why that might be, versus first episode psychosis presentations. And there were several neurological red flags that emerged as important discriminators between the groups, and we'll continue to look at that further. But in particular, memory impairment was one of our strongest predictors, because it was present in 81% of autoimmune encephalitis patients versus only 10% of first episode psychosis presentations. And then, as we all know from the literature, things like viral prodrome seizures, decreased level of consciousness also were typically more predictive of autoimmune encephalitis being the ultimate diagnosis versus first episode psychosis. So of our cohort, 18 patients had autoimmune encephalitis. 5 of those had an NMDA receptor antibody present. All of these patients had that diagnosed in CSF, not serum alone. LGI1 antibodies were found in 1 patient, GABA-B antibodies were found in 1 patient, and GFAP antibodies were found in 2 patients. But what's important is that half of our patients had no antibody found. And this really shows that autoimmune encephalitis does extend beyond available antibodies that we can test for, and also mirrors a lot of the most recent literature that suggests that phenotype is as important as a positive antibody. So an antibody that's positive with a phenotype that doesn't match isn't necessarily important, in the same way that seronegativity isn't necessarily important alone if you have a clear phenotype. Sorry, I think that slide didn't move along, but that's what we were looking at. So how did we go in terms of diagnostic accuracy, even without any clear pathway at present? So 96% of first episode psychosis patients were correctly diagnosed, and 83% of autoimmune encephalitis patients were correctly diagnosed based on initial diagnosis versus discharge diagnosis. So in total, 108 patients, representing about 87% of our cohort, were admitted with a suspected first episode psychosis. 12 patients, which is about 10%, had autoimmune encephalitis, and 4 had other medical diagnoses. 4 patients initially admitted with first episode psychosis went on to be reclassified as autoimmune encephalitis.
So, Emily, you've frozen for me. I don't know if that's for everyone.
Yeah, I can't hear it.
Yes.
Emily, if you can hear us, your screen's frozen and we can't hear you. Oh, shoot her a message.
Pretty cool.
We'll hopefully have Emily back in just a minute. But it might be a good time to answer some questions if people have got any. I can't see any in the Q&A.
Thanks, Adith. I might just jump in with one, and this is, maybe relating a little bit back to what Matthew was saying. Interesting, with the Queensland study looking at first episode psychosis at 3 to 4%, and perhaps even more. I'm just trying to numbers that Emily's now presenting in the Prince of Wales cohort. Reasonable percentages of people are coming through with autoimmune encephalitis. And what sort of response clinically should we be looking at in first episode psychosis? Is it about routine screening, or is it identifying some of maybe the traits that might be associated with that and just screening those people? Because I've no idea how expensive or how troublesome it is to do widespread testing.
Look, two things, Andrew. I think I'll answer that a couple of ways. Emily's back, but I'll answer that question while she's jumping on. It's not the cost issue is not the issue at hand necessarily. I mean, there's a certain invasivity issue, because if there's one takeaway here, it's that CSF or doing a lumbar puncture is the way to go rather than doing serum if we really want to pick people up properly. So there's an issue there around the ability to do lumbar punctures in our patients. Which is, I suppose, marginally more invasive than a blood test. But hey, Emily, you're back. I'm just answering a quick question, and then we'll go on. So it's less a cost issue, and I think the way we're pitching it here, it's more of a pickup issue, because there are consequences for getting it wrong both ways. If you get it wrong in terms of missing a diagnosis, obviously, and this is the thing that we worry about, as Emily said, as psychiatrists, but also, at the individual level, a patient and their family, you're missing something that can be treated. And the literature that we're not necessarily talking about, maybe Emily will, is early treatment is key. And we have a number of patients on our books where a diagnosis has been missed, and the consequences of that are difficult, around cognition and cognitive dysfunction in the longer term, and functional impact in particular. The flip side is immunosuppressive therapy is not without risk in and of itself, particularly as you work your way through the sort of treatment algorithm, if you will. You move from, I suppose, relatively lower risk treatments to relatively higher risk treatments as you continue to work your way through. So there are consequences either way, and I think more than anything, I guess what we're saying here is the importance of where we need to get to is to be able to pick up people in a reasonably accurate way, and then to be able to initiate and escalate treatment and use the tests. And I think this is that sort of touch point on what you said about should we be testing everyone. This idea of universal screening was introduced by the College of Psychiatrists a decade ago, and we wrote a paper 6 years ago questioning that approach, and Nicola's work in 23 sort of substantiates that. Is if you don't have an accurate phenotyping approach, as Emily said, if you can't match the presentation to the test, the likelihood of a false positive test, and this is just how tests work, it's the positive predictive value of tests, the likelihood of a false positive test is substantively higher. If you don't have a clinical presentation that matches, you're more likely to sort of pick up a test that's positive and really not have it mean what you think it's meaning. So we are, the valence of being able to access disease-modifying treatment is incredibly high. And I think this is sort of where you bring the science to it, is if the outcome is predetermined, if we go at something from the point of view of, well, I want to be able to offer this thing, and so I want this to be right, we lose objectivity. And what we're really trying to get to here is how do you objectively approach what is a very important issue. And Emily's work and Matt's work, this sort of work that we're talking about here that we've done together, is really about comparing these groups and saying what are the things that help us do that well. But back to you, Em.
All right, sorry, I must have overwhelmed the computer with a really interesting talk and it just crashed. So this is just a table that compares the psychiatric symptoms between our first episode psychosis and autoimmune encephalitis groups. So in particular, hallucinations of all forms were more common in the first episode psychosis group, so 64% compared to 22% in autoimmune encephalitis. And breaking this down further, as may be expected, auditory hallucinations were again more common, so about 60% of the first episode psychosis presentations had auditory hallucinations reported, versus 17% in the autoimmune encephalitis group. And Schneiderian first-rank symptoms were substantially more frequent in this first episode psychosis group versus the autoimmune encephalitis group. So I might jump ahead just for the sake of time, because some of the next slides will cover this. Oh, maybe I can't jump to the next slide. Oh, there we go. So this is a principal component analysis. So along the x-axis, we see that psychiatric symptoms cluster towards the left, while the neurological and organic features cluster more towards the right. And those features more associated with our first episode psychosis group did include hallucinations, delusions, and mood symptoms with loosening of associations. Whereas towards the right, we find features more associated with our autoimmune encephalitis group in this organic presentation, including altered sensorium, disorientation, decreased level of consciousness, and autonomic instability. And down along the y-axis, we also capture this additional variation with psychotic features such as hallucinations and delusions appearing more prominently in the top left, whereas rapid deterioration and disorientation appearing over towards the right. So this clustered bar graph essentially helps us separate it a little bit more visually. So the blue bars on the left represent features associated with our first episode psychosis presenters. So strongest discriminators were thought broadcasting, somatic hallucinations, and thought withdrawal or insertion, which were almost exclusively observed in the first episode psychosis group. The red bars over towards the right represent the features associated with the autoimmune encephalitis group, and the most powerful discriminators were focal neurological deficits, seizures, memory impairment, and viral prodrome, as well as decreased consciousness and altered sensorium. So our biggest red flags overall are memory impairment, and this is particularly important because this correlates well with recent literature from 2022 to 2025. So in particular, there was a Japanese study that looked at 10 autoimmune encephalitis patients versus 177 first episode psychosis presenters, all with similar rates of memory impairment to us, so 81% in the autoimmune encephalitis group versus only 10% in the first episode psychosis group. And again, another study done in 2025 by a group in Mexico looking at 164 patients with autoimmune encephalitis found that 75% of these patients had severe cognitive impairment associated with memory impairment in particular. Other important neurological red flags we've already touched on briefly. But just to move on for the sake of time, how did we compare in terms of our investigation? So there are clear differences between how we are investigating patients that we flag at the time of admission as first episode psychosis versus those we're flagging at the time of admission as autoimmune encephalitis. So MRI brain was performed in 61% of the autoimmune encephalitis presenters versus 20% of the first episode psychosis presenters. And this isn't necessarily a bad thing, because 72% of the patients with autoimmune encephalitis did have abnormalities seen on the MRI, and only 6% of those with first episode psychosis had abnormalities on the MRI. And essentially this means that we're probably scanning the correct people. And the typical changes that Matt already mentioned were those seen on the abnormal MRIs of those with autoimmune encephalitis, including hyperintense T2 flare signal changes, particularly in the limbic and cortical structures. EEG is an interesting one, particularly as a neurologist. A lot of the literature surrounding it suggests that a quote-unquote abnormal EEG is important as a diagnostic marker. However, the criteria used in the literature is very vague and very broad. So, for instance, temporal slowing is a normal variant that you may see in elderly patients. You will also see it in patients who are unwell with metabolic encephalopathy. And delta brush, which is described for the NMDA cohort of patients, is really pathognomonic, but very, very rare. So I would say from a neurologist perspective, unless the EEG shows clear interictal discharges or epileptiform discharges, a normal EEG doesn't mean anything one way or the other. So CSF analysis was performed in 100% of the autoimmune encephalitis group, but only 9% of first episode psychosis. And I guess this raises the question, based on other groups' work about whether we should routinely be doing lumbar punctures on patients presenting with first episode psychosis. It's a difficult question to answer, but I think if we're going down the path of sending off serum, we should be sending off CSF. There are certain antibodies that are better detected in serum alone, and there are others that are better detected in CSF alone. And I think you can't do one without the other. So how did we go in terms of treatment approaches and clinical course? Just move on to the next slide if I can. Maybe I can't. Whoop. So all the patients in the autoimmune encephalitis group received immunosuppressive therapy, and most required a multimodal regimen, so high-dose steroids, IVIG, plasma exchange, some even required rituximab. So there was a favourable response in this group. So 94% of our 18 patients did improve after immunotherapy, and only 16% were actually started on antipsychotics or psychotropic medications. To touch briefly on the economics of this, and maybe the economics of screening, autoimmune encephalitis admissions had a longer median length of stay, so about 37 days compared to 14 for first episode psychosis. And there's been some recent literature, mainly out of the US and China. So in particular, a study from 2020 estimated that the median cost per admission for a patient with autoimmune encephalitis is somewhere in the order of $70,000 US dollars. And of course, this is higher if they require ICU admission. Diagnostic delay greater than 7 days also increases direct costs, and length of stay is the main driver of that. And targeted autoimmune encephalitis screening in first episode psychosis in a recent study, 2022, has been shown to be cost effective insofar as early initiation of treatment, reduced length of stay, and reduced morbidity and mortality. So there could be an argument that the cost of the panels that we send, for instance, CSF and serum, which are in the order of $200 to $500, is probably worth it compared to patients who deteriorate if they are not diagnosed within a week of their initial presentation. Another point I thought might be interesting is also, what was it that led us, to have the longest delay to treatment in our autoimmune encephalitis group? So the longest delay from presentation to treatment in one of our patients was 29 days. And the thing about this patient was that she did present with more classic Schneiderian symptoms. So she was paranoid. She did present with delusions. She actually had a more manic and elevated affect. And it appears that prominent psychiatric symptoms at diagnosis kind of create a vicious cycle, because the longer it is undetected that this is secondary to autoimmune encephalitis, the more florid the psychiatric symptoms become, and the longer the delay to treatment is. So I guess building on like a framework for a diagnostic picture, recent literature suggests that autoimmune psychosis patients present more with deeply fragmented and polymorphic symptoms and really poorly systematized delusions, in contrast to first episode psychosis with more organized delusional systems, which is also seen in other primary psychiatric disorders. So features favoring primary psychosis or first episode psychosis are your Schneider's first rank symptoms, thought broadcasting, systematized delusions, versus autoimmune encephalitis, where it is fragmented. They have altered level of consciousness and accompanying neurological signs and symptoms. I think I got a warning that this is up in 5 minutes. So where we're heading with this in terms of our future direction is we hope to inform a clinical evidence-based pathway. So for instance, tiered investigation protocols with first episode psychosis being screened within 24 hours using a pro forma of red flag checklists, and investigations being based on how many of these red flags they fulfill. This is ideally to expedite immunotherapy protocols, and I think the quality metrics we can base this on are diagnostic delay, length of stay, and the economic impact. There are future biomarkers, but that's for a different day. And I guess the limitations of this research essentially is the cohort. So only 18 patients with autoimmune encephalitis over the 9 to 10 year period. It's a retrospective study, so we can only rely on the notes that were taken at the time. And it's a single center study, so it doesn't really generalize particularly well to very broad and different populations. And we don't have any longitudinal data, which is something I guess we could ideally aim for in the future about their cognitive recovery and outcomes. And that's it.
Brilliant. Thank you so much, Emily, Matthew, and Adith. Really fascinating and informative presentation, and just so critically important for those that do experience autoimmune and encephalitis. So I just want to apologise to everyone for some of the I guess technology blips that are happening with today's presentation. One of those is the Q&A icon not working for a lot of people, including myself, and it might be to do with some updates or things that people put in. But if anyone does have any questions, please, if you can add them just to the chat list, and I'll take that opportunity to ask the team. And just while we're waiting for any of those questions to come through, my first question was going to be, which essentially was your final slide, was about future directions and were you thinking of creating a red flag checklist, which of course you're already all over that. And I think that's a fantastic way to go and something that'll be really useful, particularly for early intervention services to implement. So I did want to ask, and I was curious actually, about what the sort of response rate for symptom reduction was with people who were treated with antipsychotics, and was there much symptom relief, or did we have any studies looking at that?
In the autoimmune encephalitis group?
Yes, sorry.
So what was interesting in our group was not that many patients were actually started on antipsychotics, so only about 20%. And a lot of the literature warns about adverse reactions to antipsychotics being a marker that perhaps the patient is experiencing autoimmune encephalitis as opposed to just a first episode psychosis. None of the patients in our group had an adverse reaction to antipsychotics. Most of them didn't have a significantly positive response, though, in terms of quelling their delusions, or in that patient I mentioned who had a really long delay to treatment, she remained very elevated despite multiple mood stabilizing medications being commenced.
Right. Well, I guess what's really promising out of that study is that people were identifying, sounds like 80% of these cases were identified this as an abnormal presentation of psychosis, and we're going to tread cautiously instead of just whacking people with high-dose antipsychotics, which is very reassuring to hear, and I hope that that's common practice. I don't know whether that's just Adith's presence at the site, which has made a difference there. But yeah.
Well, you do touch on something important, not so much my presence, which is wonderful, but the idea of shared working. And we sort of live our lives in this rather fallacious assumption that, you know, neurology and psychiatry sort of treat very different things. So when you talk about central disorders like this, you're treating the brain. And, you know, in terms of future directions, yes, it's red flags and all the rest of it. We can put lots of stuff in place, but it is the shared working between us and, you know, and my orientation as a neuropsychiatrist sort of bridges that gap in a way, because I work very closely with neurology. I've sort of worked very closely with Emily, and Julie Thompson, who's one of our key collaborators in this, and that sort of shared working model, and that is the future direction that clinic that Emily talks about. It is essential to be having those conversations, because, you know, yes, we're doing well, but the 4 people that did get missed and moved across, they had large delays to diagnosis, and 3 of them are in my clinic at the moment with poor outcomes. So at a group level, we're doing well, and, you know, it's the individual level, right? And that's the challenge here, is what's the valence of getting it wrong for someone? And if you get it wrong as a psychotic disorder without an autoimmune cause, you're putting them on antipsychotics. That this group, I mean, this is Mindgardens' work with CHeBA and all the rest of it, is you're putting them on drugs that leave them fundamentally with a lower quality of life, a lower lifespan, and the risk of metabolic disease. So we all know that, we talk about it all the time. You miss them as having an autoimmune disorder, and you're denying them the possibility of a rapid response to a treatment that reverses their disease. So at an individual level, it's a critically important thing to do, even if we're getting it largely right at the group level. The opposite side of it is you have papers like the one that Matt talked about at the end that came out literally about a month ago that posits that the rates are sort of nearly 100-fold, 60-fold higher than what the literature would say it was. And to be fair, we're discussing separate things. I've read, we're looking at autoimmune encephalitis as a very specific entity, and they're talking about a sort of broader neuroimmune mediated process for psychiatric disorders. But that conversation has been had in the past for pediatric neuropsychiatric syndromes. And I know that Kath Knight's on this call, and Kath's the director of the Sydney Kids Network. We've had that PANDAS conversation, which is now called PENS, and the terminology sort of evolved over time, that we have a group of neuropsychiatric syndromes within kids that might be autoimmune mediated or immune mediated if you take it more broadly. So it's this sort of gap between what is a very specific entity, like an autoimmune encephalitis, and what is a very broad entity at the other end of the spectrum is what does inflammation do for people that develop psychiatric disorders. And the further you get along that spectrum, the more fuzzy it gets in terms of causality. And if you get fuzzy with causality, you get fuzzy with treatment, and you dilute your sort of treatment responsiveness, let alone the risks of treating people the wrong way, whichever way you go. So I think this is not a call to arms as much as there is work needing to be done to get it right, because it matters to the individual. And part of doing that work is to take a more structured and systematic approach. And part of that is to work in collaborative clinics. As I said at the start, my interest and our interest as a group is what is going to have the most immediate impact in terms of care provision. We've been debating this stuff in the literature for 35 years, 100 years if you go back to the 1900s. What are we doing differently now relative to 30 years ago? What are we doing differently now relative to 2007 when MDA was published? Arguably not a lot. And I think if there is a take home, we're looking to do things differently, which is not to say we're looking to do things hastily or without caution, quite the opposite.
Brilliant. I've noticed that our time is up, but thank you once again, Emily, Matthew, and Adith, for a really great presentation. And I think people will be virtually applauding. We can't hear them, unfortunately, but thank you once again. And just a couple of little housekeeping things before we go. Just that next month we have Dr. Nick Burns delving into the world of rehabilitation psychiatry. So that will be a really interesting and practical session to attend for everyone. And also that Mind Labs have an upcoming workshop on co-design, which people are still able to register for if they're interested. Fenella has put up the QR code on the screen. Otherwise, you can just go to the Mindgardens website and see all the upcoming events that Mindgardens are involved with. Otherwise, thank you once again to our presenters, and see you all at the next session.
Thanks again for the opportunity, and thanks Emily and Matt. That was exceptionally well done, and I thought we managed to pull off the 3-speaker thing quite well, actually. So might do that again. Yeah, thanks guys.
Thanks, Andrew.